So as you can see, this is a great group of panelists. We're going to move to Rob Gibbons. And Rob Gibbons, as you will see, is a Renaissance man. He's the sort of person that could talk to you about carpets, to cars, to organ transplant, to biostatistics, to psychometrics. He really knows it all. So Rob is the Bloom Rice Professor and a Pritzker Scholar at the University of Chicago. He has appointments in the Department of Medicine, Public Health Sciences, and Comparative Human Development. He also directs the Center for Health Statistics. Professor Gibbons is a fellow at the American Statistical Association, the International Statistical Institute, and the Royal Statistical Society. And he's also a national member of the National Academies of Medicine, of the National Academies of Science. He has authored over 300 peer-reviewed scientific papers and 5 books. He writes while he sleeps, so he's one of those people. So without not delay, Rob.
Thank you, Maggie. Statisticians are people who wanted to become accountants, but we didn't have the personality. I've told that joke about 100 times, but it still works. So to the extent that I only have a short period of time, I'll tell you what I'm going to tell you. I'm going to show you about screening and measurement, a new approach to this problem of mental health disorders, substance use disorders, and suicidality. And I'm going to show you that we can dramatically increase the precision of measurement, eliminate completely the clinical or clinician's burden of measurement, and dramatically decrease the burden to a particular individual, to the patient, and be able to do this in or out of the clinic any place in the world. There have been a great number of clinical collaborators that have worked on this project. It's been funded by the National Institute of Mental Health for the last 15 years. You guys have paid about $10 million to develop all of this stuff. Maggie Alegria has helped us with the Spanish translations and also the substance misuse banks. David Kupfer, the adult psychopathology, also Ellen Frank, and David Brent on the child versions. We call these CATs, computerized adaptive tests, and we call the child version the kitty cat. Okay, so now all I have to know is how to move the green one. I am colorblind. I have no idea what color green is. I've never seen green. I think it's this one. Okay. Thank you, Maggie. This work started actually in the early to mid 1980s. We did the mathematical statistics for the Department of Defense as a part of a Young Scientist Award from the Office of Naval Research. Unfortunately, the supercomputers of the day were too slow to even do the computation, so we proved it in theory, but no one actually applied it to anything. Now, thanks to Al Gore for discovering the internet and modern server technology, we're able to do 1 million of these tests for a full battery of mental health disorders, substance misuse, and suicidality. A day on a single high-speed server. We could screen the entire US population, if we could find them all, in a single day with 300 servers. I'm interested in the science of measurement in both the physical and the social and the behavioral sciences. So what is measurement? The commonly agreed upon definition is measurement is the process of obtaining the magnitude of a quantity relative to an agreed upon standard. It's a terrible definition because it assumes we have an agreed upon standard. Not everything that can be counted counts, and not everything that counts can be counted. Albert Einstein said that. It has nothing to do with my talk, but I always start with a quote from Albert Einstein. In the physical sciences, we have truth. This is an example of silver in parts per trillion in distilled water, GC mass spec. The x-axis is truth. We have spiked samples of distilled waters with various concentrations along the calibration line, and the y-axis is the measurements that we obtained. In mental health, I can't spike you with depression. My x-axis is a latent variable, it's theta, and the only way I know it is through the manifestations of individual symptoms. Many clinicians really believe a lot in individual symptoms. Statisticians don't. They come, they're here today, they're gone tomorrow. They are the way we draw inferences to the latent variable. I don't care if you tell me you're sad today and you're not sad tomorrow. I want to know what is the severity of your depression. I want to know what theta is. And the only way I can learn what theta is to ask you way more questions than I ever want to ask you. The idea of adaptive testing is to be able to limit that burden. So in order to understand this, we need to sort of understand the difference between classical test theory, which is what you all use, the PHQ-9, the Hamilton Depression Scale, the CESD, the Beck, anything you've ever used that is scored in terms of a total score, the summation of the individual item scores, and that's taken as if it's some measure of truth of your underlying disorder. It's a lot in a sporting analogy, like the hurdles. The items are like the individual hurdles, and if I change the number of hurdles, if I change the distance between them or the height of the hurdles, I can no longer compare the time it takes to run the race. Item response theory, by comparison, this horrible picture, is like the high jump. In the high jump, the items are like the locations on the bar, and your ability is measured in the same metric, the highest height you can clear. This gentleman's going to start at about 6.5 feet. He's going to move the bar about 1 or 2 inches, and we'll know his ability. I do the high jump. I'm starting at a foot. I want to build a little confidence. I'll move it a foot at a time, and by the time I hit 4 feet, I'll do a face plant. The important thing here is that not that I'm a bad high jumper, is that my ability and his ability are measured in exactly the same metric, yet we have taken no 2 items in common. What does this allow us to do? It allows us to do CAT, or computerized adaptive testing. We freed the items from the measurement of the actual ability. So what is CAT? Imagine for a moment we had a 1,000-item mathematics test, ranging in difficulty from simple arithmetic through advanced calculus, and we had 2 examinees, this lovely 4th grader and one of my poor oppressed graduate students in statistics at the University of Chicago. Now, I could go through the arduous process of giving each of them the 1,000-item test, and I'd get a good estimate of their mathematical ability, assuming they sat still long enough to take it. However, I would have really been wasting their time. I'm giving real analysis questions to a 4th grader and arithmetic questions to a graduate student. Doesn't make much sense, does it? That's what all psychiatric mental health measurement is based on today, that you use and you use as the foundation of testing the efficacy of your interventions or the effectiveness of drugs or anything else you do in this field. I could take the PHQ-2 version of this, kind of a simple, fast, short form of this. I'd give them an arithmetic question and a calculus question. The child would get the arithmetic question right. The graduate student will get both of them right. And I'll come to the ridiculous conclusion that my graduate student has twice the mathematical ability of a 4th grader. Now, I tell them that routinely, but I don't really mean it. A better approach would be to start with an algebra item. When the graduate student gets it right, move to more difficult items. And when the child gets it wrong, move to easier items. That's what computerized adaptive testing is. And the Educational Testing Service has been using it for 30 years with unidimensional constructs, like mathematical ability. The GRE is a form of a CAT. It's a really bad CAT, but it's a form of a CAT. For complex traits like depression or anxiety or mania, hypomania, they are inherently multidimensional. And rather than just moving along the real line to determine what is the next difficulty of the next question to administer, I need to find the next optimal question in a k-dimensional space. That is the statistical problem that we solved, and this is the solution. Don't try it at home. This is not rocket science. I've done lots of rocket science. This is much harder than rocket science. So what is the CAT-MH, the CAT mental health? This is the tool that we have developed. It's a suite of now close to 15 different computerized adaptive tests based on multidimensional item response theory. What this means is we can extract the information from a huge bank of items. Our bank of depression items has 400 items in it, but we can do it by adaptively administering an optimal set of 10 items for that particular person on that particular occasion. We don't know the severity of that person. We want to move the items to that severity, but we learn it after each response to each question because we have previously calibrated this entire bank of 400 items in a large population at tremendous expense to the US taxpayer. we can maintain a correlation of that 10-item score of greater than 0.95 with the 400-item test. So now the paradigm shift is we don't have to come up with short forms that we hope will apply to everybody. The PHQ-9 is an example. You're lucky if one or two of those items are relevant for your particular severity. We can move all the items to the severity level of that particular person and extract the information that we would have obtained if we spent hours interviewing that person, administering huge banks of items. Our adult bank now has 1,500 items, and our child bank has 2,400 items, 1,200 for the child to rate themselves and 1,200 for the child, for the parent to rate the child. So we're boosting the precision of measurement and we're decreasing the burden of measurement. And the kitty cat extends that technology to children. That paper's coming out in JCAP in the next few days. What are the advantages? Adaptive tests provide constant precision of measurement. We keep administering questions until you are, the uncertainty in our estimate falls below a threshold. So the paradigm shift is from administering fixed length tests that allow the precision of measurement to vary from person to person to adaptive tests that fix the precision of measurement and allow the items, both in content and in number, to vary from person to person. The items are targeted to a particular level of severity. Adaptive tests ask different questions upon repeat administration, so we never get response bias produced by asking those same 2 or 9 questions over and over and over again. All of these measures have been validated against structured clinical interviews, the DSM-5, the CD, the KSADS. And we can use these both for screening people and also for the very important task of measurement-based care. How do you know whether or not the thing you're doing with a person is actually working? And do you have to wait until they come back into the clinic, at which they may not do? Why not monitor people in the real world? Adaptive tests are ideal for longitudinal assessments at any frequency of measurement because we're not asking those questions over and over again. Not only do we estimate the severity of a disorder, we also estimate the uncertainty in that score. Statisticians don't know anything, but we're very good at characterizing our uncertainty. What is the uncertainty in a PHQ-9 score of 10, right at that critical threshold of whether or not you're going to put that person into therapy or give them a drug? You have no idea. Is it 1 point? Is it 7 points? Is it 150 points? There is no estimate in classical test theory of the uncertainty of a single score. That's not true for item response theory. We can characterize that. These are cloud-based tests. They live in Amazon Web Services. They are scalable to any population size. Right now, we are testing people in China and India and Spain. And they have been and can be integrated fully into electronic health record systems so that at the University of Chicago, every person coming into primary care is immediately screened either the night before or when they're in clinic with these tests to alert the primary care doc of whether or not there is a comorbid mental health disorder, substance use disorder, or a fear of suicidality. So how do they work? We administer a question in the middle of the severity distribution. You probably have this idea already. On the basis of the response to that one question, we compute a horrible estimate of the severity, but also the uncertainty estimate, which is really large. On the basis of that, we go back into the 399 other depression items and pick the next maximally informative item, conditional on that particular score. We administer that. Our uncertainty shrinks a little bit, and we continue that process until the uncertainty in the score falls below 5 points on a 100-point scale. We have produced a homoscedastic world. Wouldn't you like to live in a homoscedastic world? I'm sure we all would. Diagnosis and measurement are fundamentally different things. For measurement, I want to move the items to the severity level of the individual. For diagnosis, I want to move the items to that tipping point between a positive and negative diagnosis. We developed the first computerized adaptive diagnostic scale, the CAD-MDD. It has sensitivity of 0.95 and specificity of 0.87 for an hour-long face-to-face clinician SCID DSM-5 diagnostic interview. The thing's a heat-seeking missile. It takes 36 seconds to administer. We administer this to perinatal women every week during their pregnancy and postpartum to determine the earliest onset of perinatal depression, and then go in with more sophisticated and, well, not more sophisticated, but with dimensional measures to then characterize the other, the nature of their disorder. Example applications, we did a simple study in the emergency department, excuse me, at the University of Chicago. We screened 1,000 people who came in for a non-psychiatric indication. 22% of them were screened positive for major depressive disorder, but only 7% were in the moderate to severe range in need of immediate treatment. 3% had a serious suicide risk, not only ideation, but intent, plan, or recent behavior. Not one of those 30 people were picked up by the emergency department staff. On those people who are in that moderate to severe, they had a 300% increase in future ED visits in the next year prospectively, and a 400% increase in hospitalizations. These are super utilizers, and it took us 2 minutes to figure out who they were. We see very similar results in Latino populations taking these tests in Spanish. Here's an example of a deep brain stimulation patient with no incentive. She responded to 94 daily prompts during a 6-month period to take these tests so that the clinicians could titrate the amount of electrical stimulation during the course of her treatment. What are the things that we can measure? In adults, we can measure depression, anxiety, mania, hypomania, suicidality, PTSD, substance misuse, psychosis. Yes, we can actually do self-report psychosis. We also have a clinician-guided version. Functional impairment, quality of life, and functional status and well-being of cancer patient survivors. We're finishing a borderline personality CAT as we speak. Perinatal depression, anxiety, mania, hypomania, and in children, in addition to depression, anxiety, and mania, we can also do ADHD, conduct disorder, oppositional defiant disorder, and suicidality. We can do that for the parent and child in 7 minutes in any pediatrician's office. We're also working on autism, obviously a very important measure, not self-report. What are example applications? UCLA, we screened the entire freshman class at UCLA, 6,000 kids, 4% of them had serious suicide risk. We did this remotely. Those kids who took it at 3 o'clock in the morning, for example, were immediately triaged to internet-based cognitive behavior therapy and also peer counseling network. This is the work with Michelle Kraske and Nelson Freimer from the Semel Institute. We're doing a registry where we're screening 1.8 million people in the Los Angeles area to develop a registry of 100,000 people. I'm going to go a little more quickly. We're surveying the state of Indiana for substance abuse disorders as a part of their grand challenge. We've talked about the University of Chicago, Rush University. It turns out that depression is a huge moderator of how well your knee surgery goes. So we're screening people at baseline to determine whether or not they're depressed, and we're treating the depression before we treat their knee. The United Kingdom, we're working with the National Health Service for a pilot study with the anticipation of a national rollout in the UK. Perinatal depression, we're working with Sheriff Tom Dart in the Cook County Jail. We're screening the inmates in the Cook County Jail in bond court before they get into the Cook County Jail, and also the 18,000 probationers in Cook County to try to stop this revolving door of people with mental health disorders going in and out of the Cook County Jail, the largest mental health treatment center in the United States. Although my friends in LA argue that point with me, working with the Veterans Administration to develop improved scales for PTSD. And finally, we're working with RTI and SAMHSA on a national survey of mental health disorders using the CATMH as a screening tool to determine who needs a full interview. And I think we're there. Oh, I'm sorry. We spend billions of dollars on biological measurements, yet we validate them using Stone Age clinical measurements. We can do so much better. And if I start with Albert Einstein, I'm ending with Florence Nightingale. Statistics is the most important science in the whole world, for upon it depends the practical application of every other science and of every art. Thank you very much.